We delivered as we promised, and today we are privileged to have Dr. Amos on the table. He's going to explain to us and tell us more about a certain clinical condition called clubfoot. So, Dr. Amos, turning to you, what is this condition called clubfoot?
Clubfoot is a gross deformity of the foot that is giving it a stunted, lumpy appearance.
Okay.
Yes.
So, what could be the cause of this clubfoot, or what are the causes?
There's no known cause of clubfoot,
Okay.
but we have types and factors that are linked to the types of clubfoot.
Okay.
Yes. And for example, we have idiopathic, and it has some factors like intrauterine mechanical factors.
Okay.
We have heredity, and we have abnormal innervation, and the last one is developmental dysplasias or arrest.
Okay.
Yes. And we have secondary type of clubfoot, that is neuropathic clubfoot and syndromic.
Okay. So clubfoot sometimes is called CTEV. Could you explain to us why is it called CTEV sometimes?
All right, thank you. It's called. Oh, thank you. CTEV is an abbreviation meaning congenital talipes equinovarus,
Okay.
and it has some patterns of deformities called CAVE. CAVE. We'll start with C, meaning covers. Covers is a highly arched foot. We have A, adductors. Adductors means forefoot going towards the midline. Then we have V, meaning varus. Varus is a heel going towards the midline of the foot.
Okay.
Then we have E, equinus. Equinus means foot that is in a plantar flexion from the ankle joint.
Okay. Yes. So, is there any clinical evaluation of CTEV?
Yeah, we have two clinical evaluation of CTV. One of them is called Piranisco. The second one we use X-rays.
Okay.
Yes.
So, what is the clinical uses of Piranisco?
The clinical uses of Piranisco is one of them is to make diagnosis.
Okay.
Second one is to make the assessment of the patient. Thirdly is to evaluate the progress of management. Then the fourth one to predict the need for tenotomy of the patient.
Okay.
Yeah.
Thank you. So, Dr. Amos,
Yes.
there are other conditions which someone might mistake for the clubfoot. How can someone differentiate clubfoot from these conditions?
All right. Good. So, clubfoot present with short Achilles tendon. It has a highly empty and small heel.
Okay.
It has a deep crease behind the heel.
Okay.
And it has abnormal crease in the midline of the foot.
Okay.
And another point is that the foot is smaller in unilateral affection. Then callosities at abnormal pressure areas, internal torsion also of the leg.
Yeah.
Then calf muscles may be wasted.
Okay.
Yeah. And remember, the deformities don't prevent walking.
Okay.
Yes.
And on X-rays, how can you know that this is clubfoot?
Yes. On X-rays, when you take an AP view, you will see that talocalcaneal angle is below 20 degrees, whereby the normal range is between 20 and 40.
Okay.
So when you see the
Angle being less than 20,
if
you know
it's
that's
20,
clubfoot.
yeah, you will
Okay.
see that you'll definitely diagnose that is clubfoot.
Thank you. So, Dr. Amos, we are going to the management. Would you briefly tell us about the management of clubfoot?
Thank you. We have two types of management of clubfoot. One of them is conservative management,
Okay.
and the second one is surgical management. I would like to briefly explain unto you this conservative management of clubfoot. We will use a method called Ponseti method of clubfoot management, whereby we'll start with the serial casting of the foot for 3 weeks with a changing interval of casts. Then after that, we'll prescribe a brace called Dennis Brown splint, whereby the child will be needed to wear for 3 months. And after that, we'll plan for tenotomy, whereby we will incise the tendonal achilles and prescribe a splint called AFO, ankle foot orthosis, whereby it will necessitate the healing of the incision site. And after that, we will prescribe a Dennis Brown splint, whereby the child will be needed to wear it during day sleeps and night sleeps. And during active hours, he will be needed to wear opposite shoe in opposite leg to necessitate healing of clubfoot and to prevent reoccurrence of clubfoot.
Okay. So Dr. Amos, what is the surgical management? I want you to take us through.
Right, thank you. When the conservative management fails, surgical intervention is required, ideally before working age. Surgical release is generally performed in a lancet with the sequential release of the pathologically tight structures via either a taco incision or the Cincinnati incision to reduce the subluxed joints. Stabilization may require the use of temporary Kirschner wires. Deformity correction should not be compromised by wound closure, and the Cincinnati incision can be left to heal by secondary intention if necessary. And postoperative casting is followed by splinting and physiotherapy. And good or excellent results are reported in 60 to 80% of children managed by the same procedure. Surgery for residual or recurrent deformity is often difficult and requires a careful assessment of the forefoot, hindfoot, and tibial torsion. Surgical procedures may involve further soft tissue release or tendon release, and also tendon transfers can be done. But in the process of fixed deformity, bony correction is often necessary. The foot becomes progressively stiffer with each surgical intervention, so we need physiotherapy to prevent the deformities.
Okay. So Dr. Amos, what's your final message?
Right, thank you. My final message for the mother who is out there with a child with clubfoot: do not be worried. Clubfoot is curable, and if you've not received any medical intervention, look for one in the nearest facility. And remember, deformities doesn't prevent walking.
Okay. Yeah. Thank you.
Thank you.
So the topic itself is so wide. So join us next time as we look at Ponseti method in details. Remember, the earlier the management of clubfoot, the better the outcome. Thank you.